My name's Gregory Lim, and I'm the chief editor of Nature Review's Cardiology. There's been a close working relationship between my journal, Dr. Jagat Narula, and the leadership team from the World Heart Federation for many years. So thank you for the invitation to participate in the World Heart Summit and to moderate this session on building healthy hearts, promotion of cardiovascular health from childhood. We have an exceptional expert panel, and I'd like to introduce them now. Dr. Francisco Lopez Jimenez, Chair of the Division of Preventive Cardiology at the Mayo Clinic in the USA. Ferdinand Sonnoy, President and CEO of the Reconciliation and Development Association. Dr. Roberto Bertolini, Public Health Advisor for the Ministry of Health of Qatar. Mark Sherbel, Executive Vice President for Advocacy at the American Heart Association. And we had a last-minute substitution. Dr. Purnima Prabhakaran, Director of the Center of Health Analytics, Research and Trends from Ashoka University in India, and our pace-setter lecturer, whom I'll introduce in a moment. Now, we know that most acquired hypertensive and atherosclerotic cardiovascular diseases do not typically manifest before middle age. However, we also know that disease processes that lead to these cardiovascular events begin early in life, indeed from childhood. Cohort studies have shown that childhood exposure to risk factors such as hypertension, dyslipidemia, and tobacco smoke are associated with the development of atherosclerotic disease later in life. And exposure to these risk factors is cumulative, so the greater the duration and quantity of exposure, the greater the cardiovascular risk. In general, heart disease goes undetected for too long, and preventive measures, if initiated at all, are inadequate or come too late. Now, a recurring theme of many of the sessions at this summit has been, wouldn't it be better to prevent heart diseases from occurring rather than waiting to treat the symptoms, which is much more difficult and, importantly for governments and healthcare systems, also more expensive. Primary prevention is better than secondary prevention, and primordial prevention is even better. Therefore, the objective of this session is to explore how promoting cardiovascular health from childhood can lay the foundation for a healthier, more resilient population. From prenatal care and early nutrition to physical activity, mental health, and school-based interventions, the panel will highlight evidence-based strategies, policy approaches, and successful community programs that foster heart-healthy behaviors from the start of life. We will also discuss the crucial role of families, schools, healthcare systems, and policy environments in shaping lifelong cardiovascular health, and address how to overcome systemic and cultural barriers to implementing preventive measures. So, to get us started, I'd like to invite Dr. Krishna Kumar, Clinical Professor and Head of Pediatric Cardiology at the Amrita Institute of Medical Sciences in India, to give our pace-setter lecture. KK, over to you.
Thanks, Gregory, and thank you again for this a real privilege to be able to speak here and engage a very distinguished panel. So these are the, yeah, thank you. Yeah, so the downward, it's moving forwards, thank you. So this is something that everybody in this audience is intimately familiar with, and that we just see, continue to see terrible numbers as far as cardiovascular deaths are concerned. But the bottom line really is that a lot of them are happening prematurely, particularly in LMICs. What's really striking, and what we've witnessed as cardiologists in countries such as India and many other LMICs, is that heart disease is killing earlier and earlier, something that we were not really conditioned to believe during our formative years. And it's clear that many cardiovascular diseases, so the WHO fact sheet incidentally lists these four conditions as the primary cardiovascular diseases that are really important. And from this standpoint, if you look at the first four conditions, that's atherosclerotic heart disease, rheumatic heart disease, and congenital heart disease, have significant early life origins. And it's something that starts in the womb and ends in the tomb. And it starts very early through fetal programming. And there's just plenty of data that suggests that fetal programming during and prenatal influences actually determine what happens eventually. And there's a lot of really good sessions that happened this morning. And then there is early childhood influences that we'll briefly talk about subsequently, and that sort of get worse during adolescence and young adulthood, that eventually cascade into a tremendously significant risk for congenital heart disease, especially atherosclerotic heart disease. This is something that really needs reiteration to this audience in particular, that low birth weight really sets the stage and programs somebody towards a lifelong risk for atherosclerotic heart disease. And that happens through a variety of pathways, and that's been written about quite extensively, but hasn't really captured the consciousness of many cardiologists across the world. But it's particularly important in countries where you have a very high prevalence of maternal undernutrition and a prevalence of low birth weight babies. And the proof is extremely compelling in terms of the quality of evidence, as well as the number of papers that have presented this evidence. The data on tracking with childhood obesity is also something that's very well known, and I think everybody is familiar with this landmark paper that showed that if you become obese early, then the likelihood that you will become obese as an adult is substantial. What I did, and perhaps the only reason why I'm here, is this particular study that we published quite some time ago. But what was striking in this study was we looked at a population, and we were screening for rheumatic heart disease, by the way. But we looked at their heights and weights and blood pressures, and we looked at the same population 2 years later. And we didn't expect to see this. But within 2 years, there was a very visible, statistically significant trend towards overweight and obesity, something that hadn't been demonstrated earlier. So that sort of captured the extent of the epidemic that's happening in low and middle income country environments, especially in the urban environments in LMICs. And the effects are widespread. So there is what we see as what we are witnessing in most of these countries is a very rapid socioeconomic transition that's happening. People continue to be challenged socioeconomically, and their position, therefore, is very vulnerable, but they carry the effects of poverty in the form of low birth weights in mothers and subsequently affecting their children. They are challenged when it comes to educating their children. The children live in very complex and very rapidly changing urban environments. They suffer from a lot of stress during their young adulthood when they're working, and they reach an old age with very little reserve to support their lives. So all this is witnessed. I mean, it's very visible in our part of the world. And what's really bothersome is the urban environment of most LMICs, and nobody's doing anything about it. The forces of globalization and urbanizations are really powerful. They're completely impacting lifestyles in form of reduction in physical activity. There are hardly any avenues. And we've seen it, I've seen it in my own children, I've seen it in in so many other children who I see on a regular basis, they are victims of advertising, targeted advertising. Most food they eat is processed. There's tremendous peer pressure. There are a host of digital distractions that further reduce physical activity. All this culminates in a tremendously accelerated acquisition of cardiovascular risk profile. So this is a reality in most urban environments, but the scale is not understood globally. I mean, the scale of this reality, the quantum of its impact, and what it's going to do in the future, I don't think has been completely internalized by people at all levels. So what we need is a life course approach. Again, this slide has been given to me by Dr. Prabhakaran. We need to have improvement in maternal and child health programs. Maternal health, in particular, maternal nutrition is very important. And then, of course, health promotion at all stages in life, starting from early schooling. And there's hardly any health education in our schools. Nobody talks about healthy lifestyle. There is very little in terms of really trying to make children acquire healthy habits early. And of course, there is a need for risk factor modification and then subsequently evidence-based therapy and prevention. So all this has to be supported through policy measures. And what was strange when I tried to actually look at public health messages and policy briefs, I was a bit surprised. I know that the new World Heart report does change the whole situation, but the one from 2023 did very little to talk about what happens in childhood and what needs to be done then. So there was really not enough emphasis on that, none whatsoever in WHO. And even in AHA, if you see the guidelines, the top 10 messages, there's one that talks about throughout life, the message number 1, having lifestyle changes throughout life, but everything else, the ones from 2 to 10 talk about adults very explicitly and actually state that this needs to be done in adults, this needs to be done in adults, but nothing whatsoever as far as childhood messages are concerned. So there's a very clear disparity that's going on between what we know and what we have to be doing. We know a great deal. I think there's enough and more to act. We know that maternal undernutrition is important, but most countries are doing very little collectively to do that, not just to prevent CVD, but for a whole lot of other reasons as well. What's happening to children? There's precious little being done across the world. And of course, the environment that most of our children live in today is toxic. It's changing rapidly. It's really a perfect recipe for rapidly acquiring cardiovascular risk, and we're seeing that happen. We're seeing diabetics at the age of in their 20s. We're seeing heart disease, MIs happening at 28, 29-year-olds. So we're seeing that happen at a pace. It's worrying, but at the same time, there's absolutely very little being done at all levels. What we need to do is to provide the knowledge, have people really start to think deeply about it, change the education, look at people and teach them how to look at children and have them look after themselves better and empower them with their knowledge to actually, existing knowledge, they can become instruments of change, really. And then, of course, the hard thing is to provide an enabling environment to acquire healthy lifestyles. So I'll stop with that and we can start the panel discussion there.
Thank you so much. Dr. Lopez, would you like to come up and join us on the stage? I realize we're a chair short, but I think that's going to be solved for us. Perfect. Thank you so much, KK. That's really set the scene really well. So perhaps I could start by asking Dr. Prabhakaran to just talk a little bit about your experience of public health in India, and what are the sort of critical early life factors that influence long-term cardiovascular risk in the population, and what can be done to address these risk factors?
So, good afternoon, everyone, and thank you, Greg, for the questions. And I think the context was laid out beautifully by Dr. Krishna Kumar's presentation. Thank you for the opportunity to participate in this panel. I talked to environmental health earlier today, but this was my first love, working with birth cohorts, so I'm very happy to step in. I think what Professor Krishna Kumar laid out for us was really the principle that was set forth by Professor David Barker in the early 80s, which I think maybe the new age cardiologists don't definitely relate to, so I think it's important that this is part of the discussion today. The Barker hypothesis actually spoke to the early life origins of heart disease, not really the childhood. We actually really need to start upstream. It's about what happens during pregnancy and early stages of pregnancy right through the childbirth. There are insults that can result in structural and functional abnormalities of fetal growth. That sets the stage really for increased propensity to heart disease later in life. And I think the whole world of research, there's a whole school of researchers that work around this concept of what was earlier known as the fetal origins of adult disease, FOHAD, which then became the developmental origins of health and disease, DOHAD. And the whole school of researchers has done work on these early life determinants of adult disease. And I think what we really need here is to marry that school of researchers with the adult researchers here, who are largely adult researchers, and look at the adult risk determinants, because what we need now is to move from early life origins to a life course approach. So the whole theory of life course approach speaks to the accumulation of risk. So a mother who's having suboptimal nutrition and gives birth to a low birth weight baby, who then passes through the life stages in different environments. One example is the rapidly urbanizing environments we have in developing countries, where a child born small is subjected to rapid weight gain, not least because of maybe the grandmother. It happens in a lot of cultures where they are feeding the baby and want them to catch up weight, but also because of the external environments, the access to processed foods. And what really needs attention is that age of adiposity rebound. Now, this is an important metric that we need to look at through the life course of a child. What is that earliest age when the BMI starts rising? And I think that's an area that calls for attention in the fact that we have been focusing a lot on addressing maternal undernutrition, thinking that improving birth weights means we've set the problem, we've corrected the issue. But what happens is the perpetuation of this risk, the accumulation of risk because of unhealthy environments, leading to adiposity rebound at earlier and earlier ages. So if you track people's, he showed us the obesity trends. If you track a child's the obesity trend, it tracks through life. And a lot of this is because of the environments that they are placed in. And I think it's important for us to kind of pay attention to the fact that the maternal nutritional supplementation programs really need to be paired with school health programs, adolescent health programs, because any benefits that accrue from maternal nutritional supplementation, improving birth weight, can get undone if the children are in unhealthy environments. So I think we have a classic program. It's a flagship program of the Ministry of Women and Child Development in India. It's called the Integrated Child Development Scheme, started in early 70s actually, which used to focus on supplemental nutrition for pregnant mothers and children under the age of 5 years. A randomized controlled trial of this study showed actually that the birth weights improved by a small amount, 60 grams, which seems small, but for a country like India, it's important. The same children followed up later in life lost those benefits. They accumulated CVD risk factors, which really shows that any gains gained by attention to maternal nutrition are lost if you don't adopt a life course approach. And I think that was beautifully shown by Dr. Krishna Kumar's presentation, that attention across the life course is really what can address cardiovascular disease later in life. So healthy children needing attention very early on in life is what can help us address the NCD problem, I think.
Great. Thank you so much. Francisco, maybe I can turn to you next and ask, sort of on the basis of your research and your clinical experience, so what are the most impactful interventions that we can have to, intervene in early stages of life and prevent the development of cardiovascular disease later on?
Yeah, excellent point, because there is definitely a lot we can do early on in life to prevent cardiovascular disease right there and impacting the life course of the children's cardiovascular health. There are many, but I will just mention some that have shown to be the most efficacious. One is education, and for children to understand the importance of eating healthy and moving around and being active from early on has shown to be very good. I don't know how many of you are familiar with some of the studies that Dr. Valentin Fuster, prior president of the World Heart Federation, has done in conjunction with a TV show in the US, Sesame Street, and where he created a character that actually promotes cardiovascular health among children. Now, when he first proposed that, people were laughing, like, what are you talking about? This is just to entertain children. But he said, well, we can entertain children and educate them in a way that they choose the right things, not only for food, but also for being more active. I think we many times underestimate the powerful effects of early intervention, educating children, because they are really like sponges that absorb everything they have around. And if part of it is good education of cardiovascular health, that is one. Educating the parents is also very important. And we teach them how to take care of themselves, but we also have to emphasize that they need to pass this to their children. The other thing is about the role of digital technologies in this. And I will say that digital technologies, screens, can be used for bad or for good. And most of the times are used for bad because children are just sitting in front of the TV or in front of the computer or in front of the tablet or the cell phone. But we know there are applications, there are games that actually are meant to move around. You might remember some of those video games that the competition was actually related to activity with the camera that will create an avatar of the children. So I will summarize that it is primarily on education, teaching what is important, and I can also spend a lot on the concept of built environment, but that is something that many times is beyond our reach. That's a political public health policy intervention, but definitely built environment also matters, having walkable streets, green areas, parks, and also accessible, nutritious food for everyone. But again, it's important, but we recognize that that's oftentimes beyond of our reach.
Thank you so much. And maybe now I could turn to you, Ferdi. Let's sort of think about now the children themselves. So you're a youth lead worker sort of working at the community level. So maybe you could tell us a little bit about the work that you do and how you sort of engage young people in cardiovascular health and the role that sort of peer leadership plays in promoting good behaviors.
Thank you very much for the opportunity to actually be here to the World Heart Federation and to participate. And I think this is really an important topic for me. It touches my heart because my son was almost diagnosed of CHD. And that was almost like an error when I received the call. And in the end, it happened that was not the case. But I remember taking a very deep breath and thanking God for that. And then it struck me that my core work, which is on NCD prevention and control, primarily, it occurred to me that my son does not need to have a CHD before I have very strong passion for the domain of work that I have chosen. And that was a huge call for me. And that really further inspired my commitment and focus on non-communicable diseases, including cardiovascular diseases. So in Cameroon, I've actually led the establishment of the National Youth NCD Action Network, and we are focused on raising awareness and training for raising awareness, advocacy and training for advocacy, supporting for walking the talk on CVD and other NCD prevention, and also we're using the need of several youth for allied skills, life skills, to attract and to engage so that we can have more youths educated, more adolescents educated, and they really get on work on NCDs. As I was doing most of my work on non-communicable diseases, I realized that so many youths do not have a focus on health. They have a focus on how much money they should make. We have a focus on what will become in the future. We have a focus on many other things, but hardly the health part. And so it's important to actually use these other areas of focus to draw attention and to create spaces and environment. And that's what we've been doing in the National Youth NCD Action Network in Cameroon. There's also other things we've been doing policy-related, like advocacy for the establishment of the front of package warning levels in Cameroon, and also taxation for SBs and sweetened beverages in Cameroon. And that is in process right now. And so, yeah, those are some of the things that we're doing for prevention.
Great, thank you so much. And you mentioned advocacy there, which I think is a good opportunity to turn to you, Mark, because that's what you do, I believe. Yes. So from an advocacy standpoint, what are the sort of the most urgent and effective policy levers that you've seen that can actually promote heart health? And thinking sort of particularly in terms of nutrition, physical activity in the school environment. And I'm just going to add as well, I know you're quite keen to also talk about involving people with lived experience, so maybe you could say something about that as well.
So, no, and I really appreciate this opportunity to be a part of this esteemed panel and being the individual here that works full-time in passing public policy and advocacy, and really having the privilege of leading that work for the American Heart Association, where at any given time, we have about 500 active issue advocacy campaigns at the community level, at the state level, nationally, and supporting work internationally. So I think the experience we get there, when you ask what is the most urgent or effective means, it really is defined by what is the opportunity in your country, in your community. I think Dr. Neal said it best, is you have to be prepared for that opportunity when the window opens, where the political stars align, where there is the opportunity to pass policy, to be able to seize that moment. And that takes a lot of preparation to have those evidence-based policy interventions ready to go when you have that opportunity. And thanks to the work of so many here, we have those evidence-based policy interventions. We talk about early nutrition, healthy school meals, and setting those nutrition standards to be critical in really being able to kind of start off with those healthier dietary habits early in life. Making sure that those reflect lower in sugar, lower in sodium, really focused on all the the guidelines that we developed. I would say we've had success in the United States of really establishing those nutrition standards, even though it's so critical to be able to preserve and protect those, because there's always industry interests and others wanting to kind of reduce those standards. I would say that also critically important is to reduce the stigma associated with individuals being able to afford meals in schools. We had a natural experiment in the United States where during the pandemic, all school meals were free. Obviously, they were delivered remotely, and then when kids came back to school, they were free. And states across the country are now continuing that pattern. And the great thing about it is where we're seeing success is, there's a cost associated with providing healthy school meals for all. But if we can pass excise taxes on sugary beverages to help underwrite that, it's a double win. We have states now considering that. We have the state of Maryland considering that, passing an excise tax on sugary beverages to be able to underwrite the cost of providing healthy school meals for children. Regulating the industry, front of pack labels, nutrition disclosures, really making sure that we are removing, as you think about school, kids' meals in fast food restaurants, making sure that those are healthy, and continue to make sure that we do have marketing restrictions targeted at children. The other thing that we haven't really talked about a lot here today, but I would just add, in addition to physical activity and making sure that there's walkable and bikeable communities, is also the issue of tobacco, where we have another industry targeting our youth. Certainly, it started with traditional tobacco products, combustible tobacco products, transitioned to e-cigarettes, but today we're seeing with these nicotine pouches, again, addicting another generation to this use of tobacco products. So a lot of policy opportunities, but again, I would just reinforce, it is really looking at what is doable in your community and really being able to mobilize youth, as we talked about, as advocates. We just had kind of inspiring stories about engaging patients and their lived experience to be able to advocate for public policies. Equally critical is getting the voice of youth, to be able to kind of get them to use their power, their agency, to be able to go to their policymakers and be able to describe what's going on in their schools, in their community, and how they want a difference and how they're expecting their elected officials to be responsive. We have the opportunity to support them with training and educating them about how to be good advocates, and then be able to support them with the tools that they need. So really a great opportunity to continue to elevate the voices of youth. And the great thing about elevating the voices of youth, they are our leaders tomorrow, and they will be civically engaged throughout their lives.
Great, thank you so much. And if we sort of carry on up the, the government levels, so if I turn to Roberto now, and so you work with the Ministry of Health in Qatar. So what steps have you advocated to them to take to integrate early life cardiovascular disease prevention into their national health policies? And how do you envision sort of these being scaled up across the region?
Thank you very much, and also I'm very pleased to be here in this panel. What I heard was extremely interesting and very positive. But I would like to make a provocative question to all of you. I mean, how comes that with all this evidence, knowledge, and goodwill, and community involvement, we see this epidemic? We see this problem growing. It seems that we are like, acting in a sort of environment where we exercise certain type of pressure in one direction, but there are too many other pressures which are going in exactly the opposite direction that we are not able to stop or even to limit. So here I see a lot of responsibility of the governments, a lot of responsibility for the lack of regulation, and also there are responsibility of individuals, yes, of course. But I mean, I worked in WHO for 20 years, and I remember one of the main, let's say, messages that WHO was releasing was make the healthy choices easier. And I think we are not making the healthy choices easier because the prices of healthy food is higher than the price of junk food, that the physical activity is not encouraged because, there are pressures in the environment through social media, through cell phones and everything, which is pushing people not to move. And it's true, we have some very interesting applications that can be used. We had used one in Qatar during the World Cup called Jam Move, which was encouraging children to move. But nevertheless, there are many other things that keep people stuck on that screen and without moving. That's another thing. And so I don't want to be pessimistic, but just want to say, let's be realistic also. Let's try to look at the reality as it is, not as we would like it to be, which I think sometimes, is our, let's say, retro thinking somehow. Anyway, going back to your question, Qatar is a country with a very high prevalence of obesity in young and adolescent. We reach 40% of overweight and obesity between year 7 and year 14. And there is also a very high prevalence of obesity among adults. We are getting 70% overweight plus obesity and 40% of obesity. So this means that also in the prenatal period, the likelihood that the children are exposed to an environment which is actually not the ones that they should be exposed to, I mean, also the mothers are obese and so on and so forth, create conditions which are difficult to handle. And in addition to that, there are something that I would like to emphasize here. I mean, the cultural context. I mean, we are talking about evidence-based programs and projects which are developed in Western countries, North Hemisphere, maybe South Hemisphere, Australia, or some countries in South America or South Africa, but not many are done, for instance, in the Middle East. And where there are conditions which are related to desertic environment and a very hot summertime, so it's difficult to have physical activity outdoors and so on and so forth. So are conditions within which recommendations which are correct, but when they are applied in certain contexts, do not have the same effectiveness simply because the conditions do not allow them to be there. If you think about it also, the way of eating sweets in certain cultures, sweets are a moment of celebration, so a moment of family reunion. I mean, so it's something that is difficult to contrast this way. But anyway, we did a lot during the last years, both in terms of regulations, like increasing 50% the price of sugary beverages. Although I have to say something that applies to this, but also applies to many other measures, I would like to make an appeal to all of you to think about much more to the evaluation of effectiveness and the attribution of changes to something which has been done at the policy level. We are very good in clinical trials for drugs or for other things in a very controlled environment, but how certain measures work in the real life and how they really impact obesity or overweight, it's difficult to evaluate. It's very difficult. We have tried to do something like this during the World Cup. You will remember the World Cup in Qatar a few years ago. We did a project called Sport and Health, and we did encourage, we did something which to us seemed to be very innovative, like promoting healthy food in the stadium. I mean, when you go to the stadium, usually people eat hot dogs or something, or Coca-Cola or something very, not very healthy. We made sure that at least 30% of food available was healthy according to WHO criteria, and this was fine. But then to measure how much this changed the attitude of people towards food in certain environment has been extremely challenging, almost impossible. So I just want to say that, just to conclude this, of course we did also a lot in terms of school. I mean, we are doing a project for healthy canteens, just banning junk food in the public schools, which is also a very important initiative. I spoke about physical activity. I mentioned physical activity as we use big events. I mean, and I think also this is something I would like you to think about it. There are a number of things happening in the world every day. I mean, championships, big events, gatherings. Let's use all this opportunity to promote health and not confine them to specific projects in specific contexts and so on and so forth. Just use what the people do. I mean, watch a soccer game or watch, or go to a stadium or something like that. So I think we use that opportunity also. And again, the issue of attribution and measurements of impact is a question, but I mean, it's something that I want to emphasize. And this is okay. I think I stop here. I can say more other things.
No, that's great. It's all about making it easy, isn't it? And making it relevant to the real world. It's really important. We've got probably a couple of minutes left if we overrun slightly. But if we start at the far end, I'm just going to ask each of you for about 30 seconds to just describe the one policy initiative that you would want to advocate and implement in order to promote cardiovascular health from childhood. If you could have a carte blanche wish list, what would you advocate? Do you want to use the microphone so that everybody can hear?
Yeah, educating early, making it fun.
Brilliant.
Measure the impact of your interventions and use digital tools.
Yeah.
Yeah, it's hard to add to that, but I would say again, excise taxes on sugary beverages. And one thing we're also focused on is in supplemental nutrition programs, getting sugary drinks out of those nutrition programs. SNAP for the United States, there's no reason why the taxpayers should be subsidizing sugary beverages.
I think starting early is important. So I think integrating programs that are focused on maternal and child health with school health programs will be the key driver.
Just out of the box, widespread sports celebrity endorsement of healthy lifestyle. We haven't used that opportunity enough.
That ties in with what Roberta's saying about using events that
Big
you
events,
can,
well, big people.
but endorsements as well.
People,
Yeah.
so children look up to sportsmen as
Yeah.
role models. So they haven't been doing enough about this.
I'll say we need to really invest in education. Lots and lots of education for adolescents and parents. Lots and lots of it, and measure it. That's an area where it's difficult, especially when it comes to public campaigns. Awareness is often just, called as, oh yeah, let's raise awareness. But the step further is raise awareness, but measure how impactful that really is in the communities. And for me, it's education to the parents and for adolescents.
Great, thank you so much. I mean, there's nothing more important than the next generation. So thank you all for your expertise. We're a little bit over time, but can you join me in thanking our panel and the discussion we've had? Thank you.